Thank you, everybody, for joining us today for this exciting session that we're going to be talking about choosing wisely and achieving control with BTK inhibitors in CLL. We're going to start with a. This is the. Let's move on. There we go. So it's just some general instructions. You can scan your code to ask any of us questions. I want to welcome my fellow panelist, Dr. Daniel Addison, a oncocardiologist from Ohio State. Matt Davids, a phenomenal physician scientist from the Dana-Farber. Dr. Paolo Ghia, from Italy in Boston, correct? Two places. Is it three now? And Dr. Jennifer Woyach from the Ohio State University. I want to thank, PeerView for providing this session and AstraZeneca for providing an unrestricted educational grant for the symposium. All right, we've got a lot to cover. So again, you can view the slides and practice aids now, and feel free to download them and use them. And for sure, some of the slides at the beginning of the session, we're going to go through quickly because Dr. Daniels and Woyach have a lot of slides to talk about. So let's just start with a baseline question. In your practice, which of the following represents the greatest challenge to your decision-making in the CLL setting? The presence of high-risk factors, choosing between continuous BTK versus fixed-duration venetoclax, choosing among available BTK inhibitors, therapy-related adverse events, or the presence of comorbidities. So that's good. So can the audience hear me talking? Yeah. Okay, good. All right. Y'all are just deaf. No. So
Here we don't hear anything, so hopefully.
So we've been blessed in CLL with a number of approvals and of medicines, both the covalent BTK inhibitors, the BCL2 inhibitor venetoclax, and hopefully soon a non-covalent BTK inhibitor, pirtobrutinib or nemtabrutinib, or others that are following. Where do these therapies follow? First, we've pretty much, except for a small category of patients, ditched chemoimmunotherapy, and we have these big choices between acalabrutinib plus or minus obinutuzumab, zanubrutinib or venetoclax plus obinutuzumab, and then pretty much reversing these in second line. Ibrutinib is still here, and but is a first-generation molecule, and the combination, which is approved across, in Europe, but not in the U.S. of ibrutinib and venetoclax. We're blessed that these drugs work in high-risk patients, the 17P group, with pulling this from multiple studies with ibrutinib. And these data from the Elevate treatment naive point to a question that we'll talk about a little bit later about the benefit of obinutuzumab in the era of kinase inhibitors and their use with BTK inhibitors. And there'll be an update about this at ASH. Similarly, we have data with the other second generation BTK inhibitor, zanubrutinib, showing, again, that this is a great drug compared to everything else that we had before for 17P CLL. And despite this, though, the use of these drugs in the real world, is still a moving target, and we have a lot of room as physicians to educate people. In that only a subset of patients are tested for TP53 in the U.S. And I think what's tragic is patients with 17p or p53 mutations, in some cases, are still getting chemoimmunotherapy, which we all know doesn't work. We also have the challenge. More of these data are derived from ibrutinib, our first generation BTK inhibitor, that patients over time don't tolerate these medicines. In the real world, 42% of patients discontinuing ibrutinib. Similar finding, say, in the Danish experience. And while these adverse events are seen most frequently in the first 6 months, it's the gift that comes with, it continues to come with time, that we still see late onset of AFib, hypertension, and I think with ibrutinib, as I say, if you treat somebody long enough, they will develop hypertension in most cases. So our goals today are to augment your knowledge on the efficacy of BTK platforms in CLL, and to talk about the safety considerations. And as we planned this, we really wanted to pull somebody who's not in our field, who's an oncocardiologist, and who really thinks about this problem of hypertension, atrial fibrillation, ventricular arrhythmias in a different way than we do. And then, to talk about new combinations coming forward. So this is our team that we'll be presenting. And so we're going to go to a baseline. We're going to go to a baseline poll again. Say, what treatment would you select for a 70-year-old patient with symptomatic CLL who's unmutated, has deletion 17p on NGS, and has comorbid hypertension? Any covalent BTK inhibitor, ibrutinib, acalabrutinib, zanubrutinib, or avoid the BTK inhibitor completely. All right. That's a good. I think everybody. We're starting where I figured we would start, and let's go on. Let's go on to a second question. Which strategy would you pursue when planning to address the potential cardiovascular complications related to a BTK inhibitor? First choice is I'm not sure. Second choice, consult with a cardio-oncologist. Third choice, consult with a cardio-oncologist once treatment begins, or is consult before starting treatment. All right, I think that this is a great answer. It's a great choice of answers, and we're blessed. Hopefully, at most of our centers to have access to a cardio-oncologist. So we're gonna sort of have an engaging discussion. We're gonna have an engaging discussion now about a patient, say with CLL on a BTK inhibitor, and this is Eric. He's 70 years old. He's symptomatic with CLL on a BTK inhibitor. He initially presented in 2019 and was watched. He was started on ibrutinib. Say he has hypertension that's maintained with an ACE inhibitor, and he has deletion 17p. So I'm going to start with Dr. Addison to sort of give some thoughts on this question. What additional testing might we have considered from a heart standpoint at pre-treatment, and is this the type of patient that you would typically see in your cardio-oncology clinic?
Thank you, John. I hope everyone can hear me. If they can, I'll proceed. So, I think in this setting, in terms of thinking about this patient really only has a baseline hypertension and age as far as their baseline risk. and they will initiate ibrutinib, which we know is potentially pro-arrhythmogenic in this setting. But practically for most in the community, we would generally at least consider a baseline ECG and a baseline echo, really for risk stratification in this setting. Beyond that, I would not necessarily say that a lot more has to be done in the absence of baseline known arrhythmic disease or baseline heart failure. Similarly, as far as assuming, or the questions are going a little fast, but I think the second question was about engaging cardio-oncology. And really, at baseline, if you have access to a cardio-oncologist, yes, many of these patients can be referred pre-treatment. I think practically in the community, there may not necessarily be enough cardio-oncologists to really see all of these patients, but at least some baseline knowledge of at least getting an ECG and an echo in a patient who's at relatively higher risk to potentially develop AF will really go a long way in the management and stratification of this patient.
All right. So this scenario becomes more complicated because this patient develops rapid atrial fib, 4 months, requiring an ER evaluation. He starts on his metoprolol. His ibrutinib's held. We leave out that he has a rapid tumor flare that's treated with steroids, and he's resumed. He converts out of AFib, and then is resumed at a lower dose of say 280 milligrams. The atrial fibrillation returns, and say, I'm going to stop. I'm going to stop there. He gets an echo. He has normal EF. Paolo, how do we manage that patient?
Yeah, no, I wanted to make a comment about what Daniel said, which is absolutely correct, that we have to seek for a cardio-oncologist if you have one. But from my point of view, I would really prompt and take the start of a BTKI as the chance and the occasion to seek for a cardiologist in general. So you start interacting with your cardiologist, and then also the cardiologist will start piling up experience with BTKIs, because many probably don't have even experience with the drug. So that's what we saw with our colleague who was a cardiologist. Now he has been promoted to be a cardio-oncologist, but because he developed an experience on using BTKIs, in particular ibrutinib, for many, many years.
So I want to get us back. That's a great point. So what would you do with this patient? You see that they resumed, but at the 280 milligram dose, when AFib recurred on ibrutinib, would you discontinue?
Yeah, now, actually, that's what, unfortunately, it is prescribed in the SPC, so we have to decrease, we could even stop and discontinue BTKIs and ibrutinib in particular if there is a high-grade atrial fibrillation. In the past, we were not discontinuing, we were not decreasing the dose. We were all happy, in particular the cardio-oncologist, to take care of the patient under full dose, so that they could adjust the antiarrhythmic treatment, the anticoagulation, so on and so forth. So nowadays we have to follow the rules, and therefore we have indeed to go being symptomatic, rapid, so probably defined as a grade 3. We might want to discuss, having the cardiologist here, what we mean with grade 2 and grade 3 in terms of atrial fibrillation, but that's another point. So this is exactly what we would do. So we would try to keep the patient on the treatment, because now the atrial fibrillation is there.
So, Dr. Woyach and David, what would you continue with the ibrutinib with the dose reduction?
So I think that this certainly aligns with the package insert of ibrutinib, and as Paolo mentioned, years ago when we had one BTK inhibitor to choose from, we absolutely would do this or continue on the full dose. Now we're lucky that we have 2 second-generation BTK inhibitors, and so normally in clinical practice, if I had somebody on ibrutinib who had AFib, I generally would stop the ibrutinib and switch to a second-generation BTK inhibitor.
Yeah, I would have a similar approach, unless it was a patient who had been on a BTK inhibitor for a long period of time and was already in a very deep remission, and maybe you could pause therapy entirely and give them a break. But in this case, only 4 months, I think you'd need to switch to second-generation BTK.
Maybe if I have to give a non-US perspective, in some countries, we cannot switch between BTKIs. So that's the thing I want to reassure. As I learned from the cardiologist, is that the patient has atrial fibrillation, nothing else can happen, so you can keep it safely also on the same drug if this is the only option you have.
We're blessed to have somebody that knows more about the heart than any of us in the room, probably. So, say, you know, Dr. Addison, what would you do? What would you recommend if this patient were sent to you?
Now, first of all, we all learn about the heart together. But I think beyond that, yeah, so I'll tackle this really in 2 forms. I think the current strategy in the US is to potentially consider, or at least open the door to the consideration of an alternative next generation BTKI. And these BTKIs appear to have lower AF risk. There is some question about, is there some still residual proarrhythmic risk? That's not completely been well answered as of yet, but generally in that setting, that is a reasonable strategy. As far as really in any setting, particularly if one were to continue ibrutinib or otherwise, generally the way that we think about AF is really about symptoms and symptom limitation. So beyond just the normal rate or rhythm control strategy plus minus anticoagulation, really the decision about really any BTKI therapy or any other therapy depends really on the patient's ability to continue despite symptoms. So if we can potentially control symptoms with something like increase in AV nodal blockers like metoprolol and others, really in many settings this may allow the patient to continue on their BTKI. And generally, as long as we can reduce the stroke risk and control symptoms, that is a reasonable strategy in many settings.
So this particular patient, I'm just curious, would this be the appropriate person, even if you're at a small center, that you would send to a bigger place to see a cardio-oncologist?
Yeah, so that's a wonderful question. I think in this scenario, if the patient were to continue to have, say, higher grade AF or, symptomatic AF despite baseline AV nodal blocker initiation, this is the type of patient I would refer, or at least allow certainly referral to a cardio-oncologist. If you have one readily available, by all means, we're happy to see this patient relatively early on. But in maybe a more resource-limited setting as far as access to cardio-oncology, then really we would start at least with these baseline approaches or strategies, and then if the patient continues to be intolerant, then refer.
Right. And sort of the last question, and this is more to our CLL doctors, and a similar patient that presents with watch and wait, has hypertension. We have 3 covalent BTK inhibitors. Is there one? Would you, for just hypertension, would you select a second generation medicine over a first generation medicine in this patient? It's a loaded question.
Okay, sure. Yes, definitely I would choose a second generation BTK inhibitor in this patient. The NCCN guidelines currently recommend second generation BTK inhibitors as the first approach.
Yeah, I agree, and particularly in a patient who already has baseline hypertension, I think that's important. I think between the 2 second generation BTK inhibitors, we obviously don't have head-to-head data. As we'll see, we have head-to-head data comparing each drug to ibrutinib. There's maybe a hint of lower hypertension with acala versus ibrutinib, whereas that was not seen in the head-to-head study of zanubrutinib with ibrutinib. So I may lean toward acalabrutinib for this particular patient.
Yeah, so not much difference here. Definitely in 2023, this is a typical patient who may develop atrial fibrillation. Is a male, is elderly, hypertension. So second generation BTKI are the choice. I might say that indeed, in a couple of studies, acala shows to have less hypertension, probably very close to background level, let's say, and so that probably could be a choice here.
It's great that we have several drugs that we can tailor to our patients. So, say, before Dr. Woyach comes up and talks about evidence for safety-informed treatment with BTKI inhibitor, oops, where'd your question go? All right.
All right, so I'm going to talk very briefly about some of the evidence for safety-informed treatment with BTK inhibitors. So these kinase profiles are probably familiar to most in the audience. For those of you not as familiar with them, so each of this is looking at all three of our covalent BTK inhibitors that are currently FDA approved. These maps, the pie-shaped slices, are kinase families. Green dots represent individual kinases. Red dots show the kinases that are inhibited by each drug. And the larger the circle, the more potent the inhibition is there. The hypothesis when originally designing the second generation BTK inhibitors that you can visually see are more selective for BTK than ibrutinib is that having more selective inhibition of BTK and less alternative targets may be beneficial for safety. And the reason for that is that we think that many of the side effects that we associate with the BTK inhibitors may not actually be due to the inhibition of BTK itself, but due to some of these structurally similar proteins. And these include things like TEC, which might be associated with some of the bleeding and cardiac toxicity, as well as the kinase CSK with some of the arrhythmias, as well EGFR is inhibited by ibrutinib specifically, and obviously that's associated with rash, diarrhea, and arthralgias and other tumors. So to kind of summarize many papers looking at safety with BTK inhibitors, a few things have come up. On the left here, you can see in that figure a number of the side effects that we associate with this class of drugs, things like cardiac toxicity, as has been mentioned, arthralgias, infections, bleeding, hypertension, diarrhea. In general, the studies that have led to the approval of these agents have excluded patients on warfarin, and there was a safety signal with warfarin when given with ibrutinib initially. So it's not recommended to continue warfarin in patients who are getting a BTK inhibitor. For patients who do develop atrial fibrillation who need to be anticoagulated, the recommendation would be to use a non-warfarin anticoagulant. Those appear to be much safer when combined with BTK inhibitors, but still do have a little bit higher risk for bleeding than if patients weren't on a blood thinner. So of course, close monitoring is indicated. Hypertension obviously comes up very commonly and should be managed with antihypertensives, potentially in combination with your cardio-oncology colleagues or nephrology colleagues. And then monitoring for specific symptoms associated with BTK inhibitors over time is really important. So, asking patients about questions related to arrhythmias, asking about bleeding and bruising with this class of medication, and then, of course, infections and secondary cancers, making sure patients are up to date with vaccines and with cancer screening. In the setting of ibrutinib intolerance, sequencing to a second-generation BTK inhibitor has been shown to be effective, and in many cases, side effects that cause discontinuation on ibrutinib or even on acalabrutinib do not recur when switching to an alternative second-generation BTK inhibitor. And as well, limited data exists thus far, but it does look like sequencing to specifically pirtobrutinib as a non-covalent BTK inhibitor in the setting of intolerance would also be useful. So going to our head-to-head studies of the second-generation BTK inhibitors compared with ibrutinib, I think everybody is familiar with these data as well. This is the progression-free survival curve from the ELEVATE-RR study. So this was a study of ibrutinib versus acalabrutinib in relapsed refractory CLL patients who had high-risk features. This was designed as a non-inferiority study, and you can see visually that acalabrutinib is indeed non-inferior to ibrutinib in terms of progression-free survival. Importantly, this study did demonstrate what was the hypothesis, which is that many of these side effects that are seen with ibrutinib do show up at lower rates with the treatment with acalabrutinib. So you can see the key secondary endpoint here was atrial fibrillation or flutter, which was significantly lower in patients on acalabrutinib compared with ibrutinib, as well incidence of hypertension significantly lower with acalabrutinib. Incidence of bleeding was also significantly lower, and I think it's important to mention here that this is primarily driven by low-grade bleeding and bruising, which is much lower with acalabrutinib compared to ibrutinib. All of the covalent BTK inhibitors at least have fairly similar rates of higher grade bleeding. As well, some of those toxicities that tend to be really bothersome for patients over time, like diarrhea and arthralgia, is also significantly lower for acalabrutinib compared with ibrutinib. And because of these, the treatment discontinuations with acalabrutinib were also significantly lower than ibrutinib. This is a post-hoc analysis of ELEVATE-RR that was designed to try to explain some of the lower grade, very frequent toxicities that are really hard to capture in a clinical trial where patients are on drug for many, many years. And of course, most patients age 75 over the course of 5 years are going to have some episode of arthralgia or some episode of diarrhea. So this study was done using an adverse event burden score, which takes into account both grade of toxicity and the amount of time a patient experiences the toxicity. And so again, looking at the ELEVATE-RR study, we see that as expected, some of these cardiac toxicities, atrial fibrillation and hypertension, are more common or more burdensome in patients treated with ibrutinib compared to acalabrutinib, as is bleeding. In contrast, headache and cough had a higher AE burden with acalabrutinib as compared to ibrutinib. Then, I don't know what that wind sound is, but hopefully it's not too disruptive. Moving over to the Alpine study, this is the head-to-head trial of zanubrutinib compared to ibrutinib. This again was performed in relapsed refractory CLL patients, but this was all comers, so not high risk. And this study was designed to look first at overall response rate and then progression-free survival, first looking at non-inferiority and then superiority. Here we see that with a follow-up of almost 30 months, progression-free survival was significantly higher with zanubrutinib compared with ibrutinib, and as well response rate as well was higher with zanubrutinib. The safety analysis here again significantly shows that atrial fibrillation or flutter was much lower with zanubrutinib as compared with ibrutinib. Hypertension was fairly similar with the two agents, and hemorrhage as well fairly similar between the two agents. Treatment discontinuations, though, significantly lower with zanubrutinib compared with ibrutinib. So wanted to end with talking about some of the principles for management of atrial fibrillation. So in patients who do have new onset or worsened atrial fibrillation on a BTK inhibitor, first thing is getting an EKG and obviously to confirm the rhythm, and an echo for prognostic management. And then of course, if you haven't already, consulting your cardio-oncologist or a cardiologist in this setting. For patients who have limited cardiovascular symptoms, you can consider continuing the BTK inhibitor. In somebody who has symptoms, discontinuation, at least for a period of time, is warranted. As well, many patients who have been on the drug for years and have a very deep remission, you can certainly hold the drug for a little while you're trying to decide whether to continue or discontinue in the future. I think that's especially helpful if you're going to initiate anticoagulation, just to be sure that you can start the anticoagulation safely and then fold back in your BTK inhibitor. In patients who are on a first-generation BTK inhibitor, again, consider changing to a second-generation inhibitor. So thinking about treatment selection in those patients who have no cardiovascular risk factors, really any approved BTK inhibitor is fine. Again, NCCN guidelines would suggest a second-generation BTK inhibitor could be considered even in patients with no risk factors. Those with cardiovascular risk factors certainly should be preferenced towards acalabrutinib or zanubrutinib. So some of the take-homes with safety: BTK inhibitors are associated with a spectrum of very typical adverse events, and the more selective inhibitors have less incidence of many of these events. Head-to-head studies show improved tolerability with either acalabrutinib or zanubrutinib compared with ibrutinib. Very difficult to compare the two second-generation inhibitors, though. And cardiac AEs, including arrhythmias and hypertension, are best managed in collaboration with our cardio-oncology colleagues. All right, so I'll turn it back over to John for the poll.
You can go ahead and do it.
Okay. So this is the follow-up poll. These are the same questions you saw before. So which treatment would you now select to manage a 70-year-old patient who has symptomatic CLL, unmutated IgHV with TP53 alterations and comorbid hypertension? Any covalent BTK inhibitor, ibrutinib, acalabrutinib, zanubrutinib, or avoid the class entirely? All right, great. So I think a little bit of a spectrum of choices here, all of which are completely appropriate. So second generation inhibitor is preferred, and using a different class of agents also would be fine, though with the caveat that with the TP53 alterations, maybe a BTK inhibitor would be preferred for this patient. So the next one, what strategy would you now pursue when planning to address potential cardiovascular complications? I'm not sure. Consult with cardio-oncology after an event has emerged, consult once treatment begins, or consult before starting treatment. Okay, great. So a lot of people chose consult with cardio-oncology before starting treatment, especially in patients who have concerning risk factors. All right, thanks.
David's is going to come up and talk to us about combinations. And I'll start with the baseline poll. Please rate your knowledge and the efficacy of outcomes with BTK venetoclax combinations as compared to first and second generation agents. I'm not sure. Limited, average, good, exceptional. Everybody choose 5.
Pharma people. Number 5.
I love it. We have some honest people. We can always learn. All right, so we're gonna start with a clinical case again. This is Margaret. She's a 71-year-old woman with treatment-naive CLL. She has B symptoms, splenomegaly, bulky and expanding lymphadenopathy, Dr. Ghia. And creatinine clearance of 53, performance status of 1, and unmutated IgVH and complex karyotype. And we didn't have a TP53. So we're going to ask an ethnocentric question here. So we're going to start with our U.S. physicians, with Dr. Woyach and David, and ask: Is this something? Would you consider a combination outside of a clinical trial?
I think right now with the data that we have and the lack of approval of a BTK inhibitor venetoclax combo in the U.S., I would probably not choose a BTK inhibitor plus venetoclax, although I think this is absolutely an excellent patient to treat with this combo in a clinical trial.
Yep, totally agree. Nothing to add there.
Yep. So ditto. Now we're putting you, we invited you to the podium for a reason.
Only for that.
So we're curious.
For my passport.
We're curious. What would the European perspective be with this, where it's approved?
Actually, just as a disclosure, it's not only the European perspective, because I plus V, for example, ibrutinib plus venetoclax is approved and accessible in many other countries in Latin America, in Middle East, Asia, and so on and so forth. So I think the vast majority of the countries actually have access. It's a gray zone. This patient, 71, probably would not be my first indication, a combination of BTKI plus venetoclax. As in the GLOW study, so with elderly patients treated with a combination versus tolorambuzine plus obinutuzumab, they showed indeed a little bit more toxicity, compared instead to the Captivate study, where we treated young patients. That would be my first choice. So same patient, 61, With unmutated immunoglobulin genes, complex karyotype, I think it's a very good option in terms of fixed duration treatment rather than keeping the patient forever, particularly if young. This patient, I have to say, one of the first patients I treated within the CLL-17 study, where also I+V is one of the 3 options, the German CLL study group, was actually a lady, 72 years old, unmutated. So at the end, she ended up, though the study is a 3-arm study with ibrutinib versus venetoclax plus obinutuzumab and venetoclax plus ibrutinib, she ended up being randomized to venetoclax plus ibrutinib. She's now undetectable MRD. She completed the 15 cycles, so at the end, no major issues.
Lots of studies addressing this question, and it's just interesting that the different perspective. So let's get to something even more controversial, maybe. What about a combination of, say, a BTK inhibitor and a CD20 antibody here? Matt?
Yeah, so we'll see some data on this in a moment. I think it matters which BTK inhibitor and which CD20 antibody you're talking about. So I would consider acalabrutinib with obinutuzumab combination for this patient. As we'll see, there's a PFS advantage over acalabrutinib monotherapy, although no overall survival advantage at this point.
And Paulo?
So again, not in every country there is access to the combination. Unfortunately, we don't have access to the combination. Again, is a gray patient, a gray zone, meaning that there is indeed an advantage in terms of PFS, which is now quite solid and increasing. The patient is 71, so she could benefit of that advantage because that becomes evident after 5-6 years of treatment. She's elderly, maybe she doesn't want to come to the hospital to get the infusion, so I think it would be more a logistical motivation rather than scientific, where indeed there is an advantage, which is good, but not exceptional, so it's really, you can discuss with the patient.
Dr. Woyach, your thoughts?
Yeah, definitely agree with the other two. It's a great therapy. She would likely benefit from the combination, but sometimes logistics would dictate that this is not the most attractive regimen for patients.
Yeah, the provocative data from your initial 20-patient series and the Elevate treatment naive, where you have this nice progression-free and overall survival. And now there's MD Anderson had a discontinuation study at ASH last year, and Memorial Sloan Kettering has a study cooking. I think an interesting point to me is this an alternative for time-limited therapy? And that's something in my practice I sometimes do if somebody's MRD negative after this. And so I'm going to throw the question to our cardio-oncologist and ask, as you look at these two combinations of venetoclax BTK inhibitor versus a CD20 antibody BTK inhibitor, are there patients from a cardio-oncology direction that you would point toward one or the other direction?
No, that's a great question. There are really no established data at this point to indicate that any additive agent targeted in this case, either such as venetoclax or even a CD20, necessarily supplements or enhances the cardiovascular risk of a BTKI, at least from the available data that we have that's a little bit more robust at this time.
So, and I think for time reasons, we're gonna skip this, and because I don't want to rob from the open session that's coming after, and ask because Dr. Davids has a lot of data to teach us about. So, Matt.
Thanks, John. All right, so we're fortunate that we have very effective continuous BTK inhibitors, but they do require very long-term therapy to achieve these benefits. And so there have been a lot of data developing in the last few years for the combination approaches that we'll review briefly here. So the first, just to show you some of the data around this question of whether adding a CD20 antibody makes a difference when we have continuous BTK inhibitor-based therapy. So we'd seen data from the US Alliance study that Jen Woyach published showing no benefit with the addition of rituximab to ibrutinib. And we have data from the Illuminate study that looked at ibrutinib obinutuzumab compared to obinutuzumab chlorambucil, but unfortunately that study did not have an ibrutinib-only arm, so we can't understand whether there's a benefit of adding obinutuzumab to ibrutinib from that study. So really the best data that we have come from the Elevate-TN study that we were just alluding to previously. Remember, this is a 3-arm study where 2 of the arms included acalabrutinib given continuously, but one of those arms also did an initial 6-month combination with obinutuzumab. So that's the top curve here, 84% progression-free survival at 5 years compared to 72% with acalabrutinib alone. So these curves are clearly separate. This is statistically significant. There's no difference in overall survival at this point, but if you're counseling a patient about what's likely to achieve the longest PFS with acalabrutinib-based therapy, it would be the combination, but of course there is the trade-off with the inconvenience of the infusions and the potential for added toxicities. Now, if you are going to consider acalabrutinib with obinutuzumab, I think it's important to think about which particular patients, based on their genetic background, are most likely to benefit. So we did an analysis of this study looking at unmutated IGHV patients. That's the top curves there. There you can see a pretty significant difference with longer PFS with acala-obin. But at the bottom, you can see when looking specifically at patients with TP53 aberrant CLL, either deletion 17p or TP53 mutation, there's no statistically significant difference in PFS. And this is actually a common referral that I've seen where patients are referred in for consideration of the combination therapy and they have high-risk genetics. And I typically advise against the combination because there you're getting added toxicity and inconvenience without the likelihood of an increased PFS. So what about the rationale for combining BTK inhibitors with the BCL2 inhibitor venetoclax? Several studies demonstrated preclinical synergies. There was a lot of excitement about this. Even just from a purely mechanistic standpoint, we know that venetoclax is particularly effective at clearing bone marrow disease of CLL. We know that BTK inhibitors can very effectively clear lymph nodes through lymphocyte redistribution and other mechanisms. Moreover, these 2 oral therapies have non-overlapping toxicity profiles. And in general, I think as a principle, when we use these combination approaches, we're less likely to generate resistance. So we had potential here for very highly effective time-limited therapy, potentially even all-oral therapy. And now we have quite a few data sets to help inform this. So one of the first studies here was from the MD Anderson, the single-center study of ibrutinib plus venetoclax. These patients had variable lengths of therapy, but most patients had 24 cycles of ibrutinib and venetoclax. You can see really outstanding 4-year PFS here, close to 95% in this frontline population. And interestingly, no difference in the patients with TP53 aberrant CLL. As Paulo alluded to, the Captivate study is a much larger multi-center experience. This is a phase 2 study, complex study that has 2 major cohorts, an MRD-guided strategy and then a fixed duration strategy. For the interest of time, just showing you some of the data from the fixed duration cohort here. So you can see that the rates of CR are quite high. So on the graph on the left, what you're looking at is CR rates 12 months, 24 months, and 36 months after this 15-cycle treatment. And you can see even a year after finishing therapy, about half of the patients or more are still in a complete remission, although this does go down a bit over time as patients begin to show some signs of progression. Nonetheless, on the right, you see the PFS looks quite promising for all patients in particular, 79% at 4 years. There is a hint that the patients with TP53 aberrancy might be a bit lower at 63% at 4 years. And then Paulo also mentioned the GLOW study. This is the phase 3 registrational trial of ibrutinib plus venetoclax compared to obinutuzumab chlorambucil. This was, again, a 15-cycle therapy of ibrutinib venetoclax compared to the typical 6 months of obinutuzumab chlorambucil. And as we know, the I plus V regimen was superior in terms of efficacy. But one of the things that I think is very informative about the GLOW study is the safety profile of I plus V. Remember, the GLOW study was an older patient population, and unfortunately there were 4 on-treatment fatal cardiac-related adverse events in the ibrutinib plus venetoclax arm. Nonetheless, this did lead to registration in the EMA and other countries, as you heard, but just kind of focusing a little bit more on the toxicity profile. So our patient was 71, so that's exactly the median age on GLOW. And you can see in addition to the cardiovascular issues, there was a fairly high rate of grade 3 or higher infections at 12%. It's actually higher than the obinutuzumab chlorambucil arm. Of course, this is not unique to this study or this regimen. This is unfortunately a problem for most of our CLL patients on any regimen. But I think what was also striking was the high rate of atrial fib and flutter, 14% all grade. And this did lead to discontinuation of ibrutinib because of AFib in a couple of patients. Now, Captivate has a much younger median age. In this cohort, it's a median age of around 60 years. You see some cytopenias like neutropenia and some hypertension at 6% grade 3 or higher. And of course, infection comes up. But reassuringly, in this younger population, the rate of any grade AFib is a lot lower at 4%. There was 1 sudden cardiac death in this study, but that was out of 159 total patients treated. So the rate does seem to be much lower than what was seen in GLOW. So these combinations are certainly highly effective of ibrutinib with venetoclax, but I think we need to think about which patient population we're selecting, and we need to take some care in older patients, I think particularly those with cardiovascular comorbidities. So Jen shared some pearls around management tips with BTK inhibitors. Since we're talking about venetoclax combinations, I thought I'd throw up a few for venetoclax specifically. We think about TLS with venetoclax, but actually that's exceedingly rare. What we see much more commonly is myelosuppression, particularly grade 3 or higher neutropenia, which is relatively common, especially when we're using this in combination approaches. But we can use growth factor support with GCSF. We may need to use antibiotics if patients are having febrile neutropenia, but that's quite unusual. It's usually quite manageable with dose reduction, dose interruption, and GCSF support. Of course, we monitor closely for infections. That remains a problem with all of our regimens. We have some GI side effects that we sometimes have to deal with venetoclax, but usually quite manageable. I mentioned the TLS criteria on the right. We won't go into detail there, but of course we do need to be mindful of following the dose ramp up with venetoclax and monitoring closely. All right, so as we kind of expand now, we have triplet data, so ibrutinib, venetoclax, and obinutuzumab. Some of the original work was done at the Ohio State with Jen Woyach and Carrie Rogers and the group there. We just saw an important publication from Stefan Silgenbauer's group and the German CLL study group, the CLL2 GIVE study, which focused on high-risk patients with TP53 aberrant CLL, 41 patients. And in the final analysis at 36 months, the progression-free survival is about 80% in this high-risk group. Excellent overall survival. You do see some of the typical ibrutinib-related adverse events, as you see in the graph there. They typically do decrease over time as patients stay on therapy, although again, hypertension and atrial fibrillation can arise later in the course. We also saw data from Jen at the ASCO meeting this past year, some of the first randomized data we've had of triplet versus doublet therapy in CLL. This is from the newer Alliance study of ibrutinib, ven, obin versus ibrutinib and obin. And you can see here there was no difference in terms of progression-free survival between these two arms. And when we do add the venetoclax, there was some increase in toxicity, particularly in the setting of the COVID-19 pandemic and infections. So we're looking forward to more mature data from this study coming along. And then we also have randomized data of triplet versus doublet from the CLL13 Ghia study, which was published earlier this year. Remember, this is the 4-arm study comparing chemoimmunotherapy to one of 3 different venetoclax-based combinations, ven with rituximab, ven with obinutuzumab, and then the triplet of IVO. And really the takeaway for me from this is that at least so far, based on MRD, which you can see on the left in the blood and the marrow, as well as PFS, as you see on the right, there's no major difference or advantage at this time point from the triplet therapy over any of the doublets. You do see slightly higher numerically rates of MRD, and the PFS is certainly favorable with the triplet. But I think if we're going to be utilizing triplet-based therapy, we would want to see a clear benefit over doublet, given the increased costs and infection risk and other complications. So no clear benefit in my mind at this point. We will have important data eventually emerging from the CLL17 study going on in Germany and elsewhere. This study is fully accrued now and is very important because it's helping us to understand the question of continuous BTK inhibitor therapy, in this case with ibrutinib, versus one of 2 different time-limited venetoclax combinations, the standard venetoclax obinutuzumab, and now a new standard venetoclax plus ibrutinib. And the primary endpoint of this study is progression-free survival. As we move further into the future, second-generation BTK inhibitors are now also included in triplet regimens that are being studied. Just showing you one slide here from the Bovin study, which is zanubrutinib with venetoclax and obinutuzumab. This is a study led by Jake Sumerai at Mass General here in Boston. 39 patients with a triplet therapy, and 89% of the patients achieved undetectable MRD with excellent tolerability. So this looks very favorable. You can see in the swimmer plot there, most of these patients are now out to 2 years and beyond and off drug and in remission. And at Dana-Farber, we've been leading a study of time-limited acalabrutinib, venetoclax, and obinutuzumab, or AVO. This was updated at the ASH meeting this past year by Christine Ryan. This was a study where we enhanced the population for high-risk disease. So 60% of the patients on the study have TP53 aberrant CLL. You can see on the right that at the cycle 16 response, that about half of patients were in complete remission by IWCLL criteria, and we saw very high rates of undetectable MRD in the blood and the marrow at around 86%. And importantly, these rates were equivalent in patients with TP53 aberrant disease versus all comers. Also important in this study is that the tolerability of the regimen was quite favorable. We did see cytopenias, as we commonly see, but grade 3-4 neutropenia was around 37%, so not much higher than we would expect from ven-obin alone. We saw some infections, including one fatal COVID infection, but very low rates of AFib, just one patient with grade 2 and one patient with grade 3. No ventricular arrhythmias, no febrile neutropenia or opportunistic infections, and no major bleeding events. So patients were able to tolerate this triplet well. Very few patients had to have dose reduction or dose holds. So now there's phase 3 data sets with this AVO triplet that are evolving. The CLL16 trial by the German CLL study group is ongoing. This is comparing the AVO triplet to the ven-oben doublet in the 2-to-1 randomization. And this is a study that focuses on high-risk CLL patients. This will be a very important data set eventually. And then the registrational trial for AVO versus AV versus chemoimmunotherapy Amplify continues to simmer and mature. We haven't seen data yet, but we're looking forward to seeing data from this study, which likely will lead to a label for acalabrutinib, possibly with obinutuzumab as well. And then I'll just plug quickly the MAGIC study, which is also ongoing. This is looking at the AV doublet versus ven-oben. One of the unique aspects of MAGIC is that it's got an MRD-guided therapy of either 1 or 2 years of venetoclax combination, and the MRD assessment is based on the adaptive clonoSEQ assay at a level of 10 to the minus fifth. So that will be done after 1 year of venetoclax-based therapy. If patients still have detectable MRD, they'll go on to get a second year, and then all patients will stop at the end of the second year of therapy with a primary endpoint of progression-free survival. So, a lot of data, we went through it quickly, but just some of the take-homes that I'd like to emphasize for BTK inhibitor combinations. First, adding a CD20 to a BTK inhibitor does not lead to improved overall survival, at least with the data that we have so far, although notably, as we saw, the addition of obinutuzumab to acalabrutinib does improve PFS in the non-high-risk patients. We've seen certainly a strong preclinical and now clinical rationale for combining BTK and BCL2 inhibitors, and we've seen quite a bit of data now on ibrutinib plus venetoclax, clearly a very active regimen in the frontline setting, but also some toxicity concerns, particularly in older patients and those with cardiac comorbidities. Triplet-based therapy is also highly active and well tolerated. I say particularly with the second-generation BTK inhibitors, acalabrutinib and zanubrutinib. But right now, we don't have any clear evidence of superiority over doublet-based regimens, so it's not something I'd be recommending routinely in clinical practice. But fortunately, we have several ongoing phase 3 studies now that will eventually help us to understand the comparative efficacy of these combinations versus our current standards of care. Thank you. Okay. All right, so I'm going to re-poll you on these questions. So please reassess now your knowledge of the efficacy of outcomes with BTK venetoclax combinations, doublets and triplets, first and second generation agents. So again, choices here are not sure of the evidence, limited, average, good, or excellent knowledge of this space. All right, great. So we see more people saying that they have good knowledge or excellent knowledge, so you were listening. Excellent, thank you. And we'll move on to, I think, one more question. Oh, nope, audience Q&A. John?
Yes. All right, great job. Thanks. All right. Let's walk up and ask questions for the last couple of minutes. I'll start with one that's come up. Is there any future for chemoimmunotherapy in any patient at this time?
Is there any?
Dr. Ghia, you look ready to jump on that question.
Is there any role for chemoimmunotherapy now or in the future for CLL?
Evo?
Chemoimmunotherapy.
No, oh my goodness. Luckily I didn't hear the question. So I have to say that it's few years that we don't use in our practice anymore immunochemotherapy. Again, the world is big, and in many countries, still also in Europe, in some countries, there is no access to only to novel therapies, and therefore immunochemotherapy remains an option. I think that one has to be very clear that patients with p53 aberration should never be exposed. Don't think about treating a patient, even in third line, fourth line, when you are desperate, they are not responding. Patients with mutated immunoglobulin genes, Bill and the rest of the crowd at MD Anderson showed, Phil Thompson showed that 15 years, patients with mutated immunoglobulin genes can be almost cured for 15 years if treated with FCR. Let's remember that that happens in 50% of the patients. The others are progressing. Unmutated patient is a difficult decision. If you have nothing else, of course, you can use it. But in general, I think the trend is really towards the disappearance of immunochemotherapy, I think.
Dr. Woyach?
I definitely agree. In an ideal situation where all the novel agents were available, I don't believe that there's a role for chemoimmunotherapy in CLL. I think the same patients who we talk about as having the benefit from chemoimmunotherapy also get great benefit from venetoclax, obinutuzumab, or a BTK inhibitor, and those would be preferred.
Dr. Davids?
I agree. I mean, it's harder and harder to make an argument for chemoimmunotherapy. I do still think about for our very young patients whether we could study ways to shorten the course of chemoimmunotherapy, to add novel agents to it, I think is worth exploring in the clinical trial setting. It's not something I would do outside of a trial. And I would say also we don't know how effective chemoimmunotherapy would be after the targeted agents in double or triple refractory patients. We have some retrospective data suggesting probably not very effective, but that would be interesting to generate data there.
This is, for me, this is the single hardest discussion for a consult a young person, because we wouldn't do something new for a DLBCL patient, to get away from CHOP, rituximab, and the last person that I presented this to was about 5 years ago, or 6 years ago, and about a year ago after moving from Columbus to Cincinnati, she moved to Cincinnati and quickly developed treatment-related myeloid neoplasia. And and I think so these long-term complications that follow these patients, even if you cure them from FCR, is a real thing. So we have a question about how these doublets that you were talking about, Dr. Davids, influence COVID, and you're thinking of COVID. COVID in managing patients with CLL and COVID and their outcomes.
I think that one of the advantages of these combinations is that they are time limited. So, most cases after 15 cycles you can stop, and so presumably then response to vaccination and risk of complications from COVID would be better at that point. I think one of the challenges with continuous BTK inhibitor therapy is that there is some compromise of the immune system even from that and vaccine response, and that's a continuous therapy. So I do like the idea of the combinations specifically with the COVID situation.
Right.
Maybe. If I can say something, maybe they were referring to a combination with anti-CD20 antibody. I fully agree with you with the BTKI plus venetoclax.
Yeah.
Actually, the patient I mentioned earlier enrolled in CLL 17. She had 2 infections with COVID during the 15 months, she recovered without any issue, because again, with BTKI and venetoclax, you stop the therapy, and after 72 hours, you are free of drugs. The issue with anti-CD20 antibodies is that they are persisting much longer. So that's the differences that we can see.
Dr. Woyach, your thoughts? Since you had a casualty, the study in the Alliance was a casualty of COVID.
Yeah. As Matt showed in the Alliance study of ibrutinib obin versus ibrutinib venetoclax, obinutuzumab, there was a higher rate of death from COVID on the triplet arm compared to the doublet arm. So I think it's a hard question, because obviously the time-limited nature is really appealing and getting patients off therapy. At the same time, I think that those data do suggest that there might be an additional risk when adding venetoclax, at least to the doublet, of course keeping in mind that all those patients also had a CD20 antibody.
I'm going to make a big plug for the APPs and the nurses that support, I think, probably all of us. And we went, as I say, the last year and a half in our practice with people getting combos and everything. We've not lost a single patient to COVID or had a patient have to even be admitted for COVID, in great part because of education of the patients to call right away, and the different interventions that we have, particularly Paxlovid and other things. And so I think, getting on top of COVID early in CLL is really, really important. It is important. We have 2 minutes left, and we're going to finish with last takeaway thoughts and from this discussion. 30 seconds for everybody. Dr. Addison, do you want to start?
I think that when we think about cardiotoxicity, particularly with BTKIs or any other therapy, that should not necessarily mitigate or reduce the likelihood of a patient receiving potentially life-saving therapy. I do think in many cases we can potentially work around. There are scenarios in which generally, yes, there is higher risk. Those who have prolonged ventricular arrhythmias, those who've had a history of sudden death or manifest sudden death, and those who have heart failure with reduced EF. Beyond this, in most scenarios we can manage. These events do matter in the long run. We do have data in the long run. The patients may not survive as well if it's unaddressed. But again, generally, this should not stop you from initiating ibrutinib or any other next-generation BTKI in a patient who is in need.
Right. And
Yes, indeed.
Paul?
My message very similar, meaning that as a hematologist, I think that we need to do a workup, a thorough cardiological workup in all our patients, including those who are going to get venetoclax, because also one of the TLS consequences can be arrhythmia. So you want to know very well the cardiac situation of your patient, not in order to exclude anyone. That's a very good point. So this is not to define who is good, who is bad, but really to know about the situation so that you can later face it much more rapidly and promptly.
Dr. Davids?
I would just add that I think that there will continue to be a role for continuous BTK inhibitor therapy for some patients. It's a very convenient option. But that being said, I hope that for most patients, we're moving more toward these time-limited venetoclax-based combinations. And we have a lot to learn in terms of doublet versus triplet, MRD-guided therapy, whether that matters or not. So looking forward to further discussions at this meeting about that.
Dr. Woyach?
I'll go back to something that you mentioned very early on, which is that we're really lucky in CLL right now to have so many great options for the treatment of our patients. And we spend a lot of time dissecting, this treatment versus that treatment. But in reality, these are all great options for our patients that are generally very safe and very, very effective. And so I just think it's really exciting to continue to do this work in this area and look at these combinations and other new agents that might even make our treatments better.
And I'll just add to that and say it's really everybody in this room that's and that are waiting for the next session that have contributed to this great place where for most of our CLL patients, we can put them at ease and say that they're probably going to live as long as they would without their disease because of the new medicines that we have. So we want to thank you for participating in this, and I apologize that we went 47 seconds over. 50 seconds now, but thank you very much. And you can download all this information at the website, and thank you very much.